Hello, my name is Terry Cunningham. I'm the president of the board of the Liver Coalition of San Diego. Welcome to another informational seminar dealing with liver disease. We have experts providing very useful information on a variety of subjects, and we look forward to you enjoying our presentations. The Liver Coalition was founded last year to fill the void created during the pandemic. Now, all funds raised for the Liver Coalition stay in San Diego and do not go to a national organization. Please look at our website for a list of our other informational seminars and check them out and see if you can gain some really useful information. I'd like to thank ProSciento for sponsoring this seminar. And now I'm going to turn it over to our moderator, Scott Succo.
Excellent. Thanks, Terry. I'm your executive director and the moderator for tonight's webinar. I'm glad to be here. We've got a great topic. It's I have liver disease. Is the clinical trial right for me? And we thought that it would be best to hear from one of our experts that serve on our medical advisory council. And so Dr. Gutierrez is an expert. He's a hepatologist and a gastroenterologist and an expert in liver disease. And he's also, in addition to being with Scripps Green Hospital, he is the vice president of clinical research and clinical science at ProSciento. And so with that, giving our presentation is Dr. Gutierrez. Dr. Gutierrez, welcome.
Thank you very much, Scott. It's my pleasure to present this topic. I have liver disease as a clinical trial right for me. I'm Julio Gutierrez. I'm a transplant hepatologist in Southern California. I practice at Scripps Center for Organ and Cell Transplantation. Is my screen being shared yet, Scott?
Sorry, give me one moment. I'm having issues making you the presenter for some reason.
Okay, I'll keep talking here. So I've had a long-standing interest in expanding access to not only medicine to my patients, but also to research. So what I want to talk to you guys about is the process of being involved in a clinical trial and who might want to participate in the clinical trial. And I think, you know, as I reflect on this more, one thing I've realized is there's some element of a stigma or shame sometimes associated with clinical trial. Some individuals may not seek clinical trials out until they're very advanced in their disease, until a physician tells them that maybe there's no more options. And at that point, many patients may start to seek out their own avenues for clinical trials. So I think the option here is really to try to find clinical trials before you get to the point that you're at a very advanced stage of disease. So it looks like my slides are showing now. So again, the title of this talk is I have liver disease. It's a clinical trial right for me. Here are my relevant disclosures. I collaborate with many pharmaceutical companies, also with broadcast companies like Telemed2U and Univision. But the reality is I have no actual conflicts of interest in this presentation. So as I mentioned, you know, when you are diagnosed with a medical condition, you may go on a journey. And in some cases, you know, you don't finish who you started with. And I think that's what I wanted to share with you on the left here in this picture of people going through the different life cycle stages of disease. And sometimes we move through these sort of anonymously or without really a clear direction and path. And we may have the opportunity to participate in clinical trials at various points of our illness. And sometimes, as I said, people don't really consider it until the end. So where are you at with your liver disease? You know, which liver disease do you have? How much are your liver doctors able to do for you? And when I think of the success I have with my patients, I think of a game I used to play when I was a child called Skee ball, where you try to throw the ball into a bucket that has a point assigned to it. And of course, you want to go for the 100 points. And if it's hepatitis C you have, then your clinician has the right medicines to cure you of hepatitis C. And this is really a standalone disease right now compared to all other diseases in liver disease and even outside of liver disease. If you have hepatitis C, you can be cured with all oral medication, low rates of side effect, and a short duration of time. The cure is durable. That means we won't be seeing hepatitis C come back unless you were reinfected or had a new infection of hepatitis C. So really, there's not much research going on with hepatitis C. How did we arrive at this point? Thousands and thousands and thousands of people participated in clinical trials until doctors were able to come up with a treatment that was so effective that now you can't even tell the treatment from placebo. And if you don't know what placebo is, I'm going to get into it in a little bit, but just remember that word, okay? What about primary biliary cholangitis? How is your doctor doing with your PBC? Well, I think the experience of many hepatologists in the 1980s was that PBC was a common indication for liver transplant. You compare that to what I experience today, we have one patient with PBC on our liver transplant list. So it's actually very uncommon to see patients with PBC require a liver transplant. And that's primarily because the drug ursodeoxycholic slows the progression of and the natural history of PBC and elongates over a longer period of time. Unfortunately, patients with PBC do continue to progress. It's just at a slower rate. Many of them experience many side effects. So I don't put PBC into the highest level, but we do have a lot of good therapies, including obeticholic acid. But really, there's more work to do for PBC. So we're not quite there yet. So there's still a lot of ongoing research for PBC. What about hepatitis B virus? Are we doing well with Hep B? Well, we are doing well with Hep B. We have a lot of new therapies, including a new tenofovir-based therapy that has lower side effects on your bones and your kidneys. But we still cannot eradicate the genetic material of hepatitis B from the liver. And that means that even though you may have a patient who's suppressed or is naturally controlling their infection, there's a risk for activation. And activation is usually deadly. In many cases, patients may require a liver transplant. But unfortunately, there's another group of patients who just won't be a candidate for transplantation if they have hepatitis B activation. So the goal really here with Hep B will be to eradicate the viral DNA from the human. And once we've done that, I will move Hep B up a notch. But until then, it remains a little bit less so than what we're doing with Hep C. What about autoimmune hepatitis? And this is a rare liver disease that we used to call leukoid hepatitis. Its characteristic feature is the presence of autoantibodies, suggesting that the immune system has betrayed the liver, stabbing it in the back and now attacking it. Therapies for autoimmune hepatitis primarily include immunosuppressants, which increase the risk of serious infections and even death. On the other hand, untreated autoimmune hepatitis can result in need for liver transplantation or even death itself. So we need to temper these risks with the possibility that patients with autoimmune hepatitis just won't get better. Unfortunately, autoimmune hepatitis is an ultra rare liver disease, and it's uncommon for us to see clinical trials in the space. And because of that, many patients with autoimmune hepatitis suffer with the current limited therapeutic strategies us physicians have. And even when we think we have a good approach to these patients, a lot of times we just don't have the data to back it up. So what you see in the space of autoimmune hepatitis is a lot of consensus-based physician expertise. You know, we have a great expert in our center, Dr. Catherine Fournette, who's really one of the world's expert in autoimmune hepatitis. When I have a tough case, I say, Carrie, look at this patient with me. What do you think? because there's no surefire therapy for these patients. So more research is needed, but unfortunately, there's not a ton of great options. What if you have liver cancer? Well, the approach to a patient with liver cancer had really stagnated for the last decade. We had made good progress, we learned to treat these patients, but we just had limited therapy that could be used as a medication like a pill or an infusion. And in the last 5 years, we've seen a revolution in the way we treat patients with hepatocellular carcinoma. We now have 6 FDA-approved drugs that can work either in combination or alone to fight hepatocellular carcinoma. However, more research is needed. And we still say, don't understand completely, for example, right now, whether some patients should just go for a liver transplant or go for advanced care with systemic therapy for hepatocellular carcinoma. So really, more research is needed. And many of our patients who have HCC, who are seen at Scripps, will be offered a clinical trial because eventually we run out of therapeutic options. So this is an area where there's still a lot of work needing to be done, but an area where we have made some serious progress. So I'm leaving them over there a little bit below Hep C and Hep PVC and HBV, but definitely in advance. I really am concerned about my patients with primary sclerosing cholangitis or PSC, because there's just a lack of therapeutic options for them. In fact, there's no therapeutic option for these patients. There's no single medication which seems to prolong survival in these patients or reduce the need for liver transplantation. And in fact, that's really the only thing we can consistently offer these patients. And it is an area of ongoing investigation, and luckily we are having many clinical trials. Dr. Paul Pockros has a clinical trial of PSC here at Scripps, and it's an area where we really need to continue to work because we just don't have the tools to help our patients. So it ends in the gut. We need to do more work. What about NASH? What is NASH? So NASH is the liver manifestation of obesity. It's when the liver starts to fill with fat, usually because the patient's obese, although we have some patients who may have slender NASH. Many patients who have fatty liver disease or non-alcoholic steatohepatitis may also have diabetes or other metabolic syndromes. And what we know about these NASH patients is they actually have a gene that's linked to their liver damage called PNPLA3. I sometimes refer this to as pineapple 3. And really, fatty liver is an area of unmet medical need. We don't have a single FDA-approved agent for it. It's one of the leading causes of liver transplantation. And many patients who have NASH won't even be offered liver transplant. So again, this is a real area of unmet medical need. We're not doing that well with our patients with NASH. It goes in the gutter. What about alcohol? Alcohol has become a special problem during COVID times. And it's very obvious to anybody who's working in the hospital that we're seeing more and more patients coming in with profound liver injury from alcohol. How do we treat this? Well, actually, there are some therapies available for alcohol use disorder, but many of them are very hard to use in patients with alcoholic liver disease because their liver becomes so decompensated. So because of that, there's few therapeutic options to actually keep a patient from using alcohol. And there's no therapeutic option that can actually heal the liver, except for abstinence from alcohol and good nutrition. Where we have made some progress for these patients is when we see very young patients with good psychosocial features, we're able to offer them liver transplant. And that's an exciting change that we weren't able to do, although it does require very careful examination of patient's psychosocial history. In spite of that, I still say that alcoholic liver disease goes in the gutter because we have few therapeutic options for them. So how many people take advantage of a clinical trial? Well, when we look at patients with cancer, we only see 1 out of 33 patients getting involved with a clinical trial. So few patients, even though having severe conditions, will seek out clinical trials. And it's also important to understand that for a drug to become approved by the FDA, it's a long process. And on average, it takes up to 12 years to see one of these drugs go from first in human to being on the shelves of a pharmacy. And what that means is that many patients won't have access to those therapies and for many years, and even may completely miss it. And the reality is, clinical trials may not be on a patient's radar at all. 85% of clinical trials fail to retain enough patients to actually fill them. Many clinical trials fail to finish on time because they're under-enrolled. Half of sites can't even enroll one subject on the study that they've been assigned. And 40% of US pharmaceutical clinical trial budget goes just towards recruitment. So if patients were more involved and integrated into the clinical trial process, it would actually bring drug costs down. And finally, what we see is 30% of patients drop out of a clinical trial. So clinical trial awareness remains low, access remains low, and there's different reasons for this. Some may be lack of awareness. Patients may not just understand that it's an option. What I am concerned about is many patients may not understand what a clinical trial participation even means. Many may be concerned about side effects related to clinical trials, and not understand completely what are the different particular trial phases that are available. The treatment that's being offered may be confusing. And finally, there's some fear of distrust, right? Patients may have the idea that they're going to be the guinea pig. They may have heard of past breaches of the medical comment where, such as the Tuskegee experiments, things of that nature. Those are all very concerning. Those are serious barriers that need to be discussed. So what I tell my patients, I said, look, I understand your concern, right? I'm going to explain to you this clinical trial. But finally, what I like to my patients to understand is I view the clinical trial participant as a hero. I see this as somebody who's actually taking a step forward and willing to participate to advance the cause of medical understanding, knowing that there may be no direct benefit to them. And that's really the key here, because in some cases, again, I'll say this word and I promise I'll explain it again later. Some patients may end up on placebo, meaning that they're not actually receiving the therapy that they thought they might receive as part of a clinical trial. So the other aspects of clinical trial participation include the inconvenience of participating in a clinical trial, travel, number of visits, maybe even some people might perceive it as a financial burden. And there may be reasons why your physician's not offering you a clinical trial. They may be concerned that they don't understand completely whether a treatment might be toxic to their patients, whether their patients are safe for clinical trials. Your physician may not even know if clinical trials are available to you. And then if a physician considers participating in a clinical trial himself to have it at his site, he may not have the necessary manpower or really feel like it's relevant to the questions that he wants to ask. And of course, it takes time. It takes time for physicians to participate in clinical trials just like anything else. And sometimes it's just easier for a physician to say, you know, unfortunately, there's no therapies available for you. So what you should understand if you're concerned about being a guinea pig is that human research is highly regulated. There's multiple regulatory steps involved to protect subjects who would participate in clinical trials. And it's overseen by special bodies such as the FDA and your IRBs, as well as other areas of public welfare. So understand that you are not participating in an investigation that's not being highly regulated. You're participating in an effort to understand a disease state which has been thoroughly vetted and evaluated for safety for patients. We're no longer in the era where physicians can do whatever they like. We have, you know, multiple people involved at every step of the way to ensure that patient safety is met. Why has this happened? Well, let's be honest. There's been some serious transgressions in the past. Very famous cases happened during World War II. And those are the Nuremberg trials that occurred, some horrible experiments that occurred during Nazi times, where subjects were exposed to very cruel experiments, and multiple other episodes in the past that eventually led to this highly regulated way we conduct human research. And I don't really want to dwell on these too much, but I think it is important to be honest why there's some barriers to care. For example, African Americans tend to be very distrustful of clinical research. And we believe that primarily stems from the Tuskegee experiments, where African Americans who were diagnosed with syphilis were left untreated so physicians could observe the natural history of untreated syphilis. There was a cure for syphilis during that time. And unfortunately, it just wasn't shared with those patients. So I think this is an area of shame for everybody, but the end result is now these are highly regulated areas, and physicians are especially trained on why it's important to have good conduct during clinical trials, and we all have a lot of pride in maintaining that. We're also helped by our colleagues at something called an institutional review board. And this is a unit that monitors all clinical trials and must approve them prior to conduct of the studies. These committees usually include a variety of stakeholders in the medical process, including physicians, nurses, and sometimes even patients. And the functions of these IRBs are really to protect participants in clinical trials and to ensure that clinical trial conduct is appropriate and keeps in mind the rights and welfare of patients. But how are patients finding these clinical trials now? Well, what we see is most patients find it from Dr. Google. And patients are seeking out information on the internet, and they're using this information that they find to connect themselves to clinical trials. How about in liver disease? Where are the chances for a patient to seek out clinical trial involvement? And I think there's a variety of instances where this can happen. In some cases, you may have a patient who has actually a very healthy liver who's asked to participate in a clinical trial for a drug that's being specifically designed for patients who have liver disease. These are usually referred to as healthy subject studies. And in these studies, oftentimes what clinicians are trying to understand is how is a drug metabolized by the liver under normal and healthy states? And these may be first-in-human studies for drugs that will ultimately be approved for a rare or untreatable liver disease. In other settings, we may have patients who have healthy livers, but they're fatty, and they may be recruited to similar studies to participate in as a first-in-human, or in other scenarios as a way of treating fatty liver. So this is an emerging area, especially of research, because I mentioned earlier that fatty liver currently has no currently available medical therapy. In other scenarios, patients with chronic liver disease may be asked to participate in clinical trials. These may be, in the past, patients with hepatitis C. And I mentioned that all those thousands of patients who participated in hepatitis C, all those heroes, made it so that we can now treat hepatitis C, which used to be an impossible disease to treat. In fact, when I started my medical career, I spent a lot of time researching hepatitis C. I never dreamed of the day that we would treat hep C so easily with pills, 8 to 12 weeks. It's really a dream come true for many clinicians. And so really, there's an opportunity for these patients with chronic liver disease, not yet with cirrhosis, but progressive liver disease, to participate in clinical trials. Those patients with advanced scar tissue in their liver, those patients are referred to as patients with cirrhosis. They have a special risk for hepatocellular carcinoma or liver tumors. there's another opportunity to participate in clinical trials. And in some instances, we also need to understand how drugs work in patients with severe liver disease. And again, this is important so we can learn to the actions and metabolism of these drugs so that we can use those medications in patients who have advanced liver disease. And finally, even liver transplant patients are sometimes called upon to participate in clinical trials. And really, so there's multiple chances where a patient can undergo a medical intervention as part of a clinical trial with their liver disease. So what is a clinical trial? Really, this is an opportunity to test the effectiveness of an intervention to treat a disease. And in some cases, we may just be trying to understand, is this new drug safe? We might not know what dose to use. So there may be several different doses being applied to a group of patients to try to learn which dose is the right dose. We may be testing new drug formulations, and maybe in some cases, we may have an oral medication, but we realize eventually that patients need an intravenous form of medication because that would be especially useful in very sick patients in the hospital. In some instances, we may be exploring combination therapy. What happens if you use drug X with drug Y? But ultimately, many times what we want to know is how well are these therapies working in our patients? So there's different phases of a clinical trial. You may hear this term phase 1. This usually is first in human and the opportunity to really understand safety. And in the early phase 2 studies, we want to know, now that we know this drug is pretty much safe, what's the effective dose? What dose is going to actually work in our patients? The pivotal study is usually the phase 3 study. And that's a longer term study to really understand, is this drug helpful? So the different phases of a trial are different opportunities to participate. There may be even some opportunity to participate in preclinical studies. Many of these are the opportunity to understand about dosing and toxicity. I mentioned the safety in phase 1 and dosing issues that we learn about in phase 2. And then finally, is this drug effective in phase 3? So all these phases of clinical trial are important. There's also different types of clinical trials. I mentioned these treatment types. There may be some where it's to prevent a disease or even early detection. These might be blood tests or ways to find hidden disease. Or finally, a diagnostic test. Which procedure to identify the disease is the best? But I think the most famous disease that many patients have heard of is the randomized controlled trial. These are referred to as RCTs. And this is usually what a physician may ask their patient to participate if they have an untreated or a disease with an unmet medical need. In the case of randomized controlled trials, a group of subjects who are relatively similar will be invited to a clinical trial. And in the randomized trial, some patients will be referred to the experimental arm so that they can try the new drug. Another group of patients in the control arm will remain on their current therapy or a placebo. The randomized clinical trial volunteers are arbitrarily assigned to these different groups, so there's no bias. So this is the chance when you're having a disease state, you're in that larger RCT group, you may end up on the experimental arm and you may end up on the control arm. Many of my patients want to end up on the experimental arm because they're concerned that their disease state is progressing or untreated. What's interesting is we see some patients in the control arm improve also in the setting of not having a medication change. And there's some reasons why this may be happening that are incompletely understood, but it actually is in some cases a barrier to understand how well a drug can work, because we see this phenomenon of patients actually improving on the placebo. And those are the people who end up on their current therapy or the placebo. That's the control arm. But these two groups are supposed to be relatively the same otherwise. And that's an important part of the clinical trial. so that we had parity between the different groups. So I've mentioned this concept of placebo several times. So placebo is usually described as a sugar pill. This is essentially a way of introducing a element of the study where there's some similarity between the control and the treatment group. And what we see is that there's some activity with these placebos, and it's really one of the things that fascinate me the most. And it is a way of understanding how the mind and body is connected. And what we see is these patients who receive placebo still have the expectation of some benefit. And because of that, the mind causes a change, usually on the neurochemical level, and maybe release, something like the release of endorphins or dopamine, which ultimately causes some change in the body. And what we see, for example, in patients who have fatty liver is when patients take the placebo, there's an improvement. And actually, if the drug's not very good, sometimes the placebo is so good that it makes the drug not look good. So, I mean, this placebo effect is fascinating. And I think it's one reason why I still encourage my patients to participate in clinical trials, because we see some measure of effectiveness even in those patients taking placebo. What we're trying to achieve in a clinical trial is really an unambiguous conclusion about the outcome of the test or treatment that we're implying. And we always strive for this ideal, but in most cases, we don't get the perfect result. And it's really an ongoing product to try to find that perfect therapy for patients like we found with hepatitis C. If you're going to participate in a clinical trial, I think it's important that you ask your clinician, what are the risks of me participating in this clinical trial? You should really understand those risks so that you can make an informed decision. And that's one of the key elements of protecting subjects that we've implemented in clinical research. We want our patients to learn the key facts about a trial before they decide whether they want to participate. And we've developed an informed consent process that allows patients to understand the purpose of the study, risk benefits, alternatives. They can understand how their records will be stored and what will happen if there's an injury. Most of all, what's important is that patients realize that participation is voluntary and that they can withdraw consent at any moment and stop participating in the study. So I encourage all my patients who are interested in clinical trials to ask for more information. Try to understand the trial as best you can. Here's some examples of questions you can ask about the research, about what would happen if you got in certain situations, what are the risks involved, what are the other financial considerations, what if you have to go to the hospital, who will pay for that, will you get paid to participate in the clinical trial? And there's some additional considerations. And, I think, take a moment to read this. You can, if you're watching this at home, feel free to pause it and study this a little bit. These are some great examples of questions provided by the Office of Health and Research Protection of Subjects. And ultimately, what we're striving for is patient satisfaction, people feeling proud that they participated in the clinical trial, feeling like they had the opportunity to get cutting edge medicine when available. And the essential problem with our current situation now is we have a number of causes of cirrhosis with less than satisfactory therapies available. And you can see all these different causes of liver disease. Essentially, the only one that I'm really satisfied with right now is hepatitis C. Outside of that, we still have a ton of work to do for patients with chronic liver disease, which is why I continue to practice transplant medicine. Because ultimately, all of these diseases will still require transplant if untreated. And so, we must keep this available as a therapeutic option because of many of our liver diseases are an unmet medical need. And really what I'm trying to prevent is my patient going to the intensive care unit, requiring intubation, bleeding from their varices, turning yellow in their eyes, developing fluid in their belly, liver cancer. Many of patients who need liver transplant never have access to it. In fact, only a tiny number of patients who actually need the liver transplant get it. It's a real tragedy. Of course, we exult in joy when we're able to get our patient to transplant, but for the most part, many of these patients, like I said, just won't achieve it. So I think that's why I really invite everybody to consider participating in clinical trials. Listen to your doctor talk about it. There's a number of different places where you can go to participate in a clinical trial. We have wonderful opportunities at Scripps and ProSciento. Both are wonderful places to get access to clinical trials. We also have UCSD in our region, Sharp, with access to clinical trials. There's a lot of opportunities. All of us investigators are always collaborating with each other, sharing research information. So you don't have to worry about the physicians not being collaborative. We're very collaborative about research because really we want to help our patients. And I think that's the true message. I want to share here a picture of my transplant team at Scripps. We have a wonderful leader, Dr. Paul Pakros, who of course founded our transplant center and is really a giant in hepatology. For me, he's a great pleasure to work with. We also have two other wonderful longtime leaders at Scripps, Dr. Jill Lane and Dr. Catherine Fournette. And then the three of us who are new is Dr. Jen Howe, Dr. Adam Dicey, and myself. And what we really are trying to do right now is support the whole Scripps healthcare network and really providing outreach throughout Southern California. And any of us would be very glad to talk to you about clinical trial options, as would other hepatologists in the region. So this is my final slide. I'd like to thank everybody for listening and potentially see if Scott's going to pop back on here now and rescue me from sharing my slides.
Sorry, I had you muted. I was muted there. Thank you, Dr. Gutierrez. That was great. I've been working in the chronic disease space for almost 25 years, and clinical trials has always been an important part of new innovative therapies, or as you said, areas where there's no effective therapies. But I've never had someone kind of walk through it. So it's been really amazing to kind of think through it and answer questions very honestly and up front so that people have the information, because they tend to hear bits and pieces, but you don't want them to hear it once they go home and they hear it from a neighbor. To hear it on the front end, I think really is transparent in the process. Can you talk about the importance of diversity? We hear a lot about diversity now, and why diversities in people of different origins and ethnicities in clinical trials, and how that could impact the outcomes.
Hey, thank you, Scott. That's a really good question, actually, and something I'm pretty passionate about. What we've observed is that access to clinical trial can be limited for a variety of different reasons. Sometimes it's the location of the clinical trial unit. For instance, if the location is very far away from, say, an underserved population, has lack of access to transportation, we won't see those people participate in clinical trials, right? Or potentially if providers aren't aware of the clinical trials themselves, and patients who don't have access to the providers who do have the clinical trials, and again, patients won't hear about it. And the end result of this is we see underrepresentation of not only females, but minorities in clinical trials. And it's been especially prevalent and obvious in what's happened with fatty liver. And we had a wonderful paper presented by Sonali Paul this year, where she showed that Going back to 2005, if you looked at clinical trials of fatty liver disease, half of research studies didn't report ethnicity. This is especially concerning given the fact that we think that Hispanics are at special risk for fatty liver disease. Later, once ethnicity started being reported, we saw that only about 10% of Hispanics were being usually included in clinical trials. So, how do you try to fix this situation? Well, I think, many investigators have already recognized this as a problem. So there is an intensive effort to include more minorities and more women in clinical trials. But I think it does require an eye to this and really try to examine your subject population. When you're lacking those, I think investigators should do their best to encourage people to participate. I think you'll also see more efforts coming from the NIH sponsors themselves to ensure equity and access to clinical trials. But I think it's a systemic problem in some circumstances. And so, what we can do now is to try to address it that way.
And with so much effort and discussion being placed on the medical home, how does the clinical trial site interface with my medical home if I've got multiple chronic health conditions? How does that coordination happen? It might be outside my institution where I get my primary care.
Interesting question, Scott. Yeah, so I think that's, there's different ways you might see research being conducted, but it's almost always going to be outside of your primary care clinic. The usual case is that even if the primary clinic is affiliated with the research center, it's going to be separated. And in part, this is related to the way research is structured and monitored. But so they're going to be separate events, but your clinical trial unit should communicate closely with your regular physicians, updating them on results, also giving them information that is relevant, like for instance, if there's an outcome that's unexpected. And I think that's always important, but you won't see a complete joint establishment there usually. There's usually some separation between the clinic and research, but there should be some collaborative effort. In many cases, your primary care doctor or regular physician may also be your research physician, but the entities are usually separated. And I think in those situations where patients are very complicated, that's the ideal situation where you have the same physician on both sides.
Sure. And you talked about a number of different liver diseases, and it's interesting because sometimes the patient is saying, I really am looking for a cure for myself. And in the early days of hepatitis C, some of those found that during those early clinical trials, but it was a small number until things got better. So some of them were heroes while they were trying to fight their disease, and then others enter a clinical trial with effective treatments, but they're looking for more effective treatments that are easier to tolerate. So the motivations, talk about the difference, but they're all good, right?
I think they're all, everybody has their own reasons for wanting to participate in a clinical trial. My concern is that people might feel shame for doing it. That's my main concern. That somebody might feel like, well, I'm just going to be doing this for the money, or that they don't understand the whole process of why they're participating. But to make this research progress, we need people to participate. We need physicians to participate, right? If physicians will participate in clinical trials, you can't find subjects, right? So the physicians need to participate, the subjects or patients need to participate. And without those people engaged, then we'll never make any medical progress. And I think, whatever the motivations were for the era of hepatitis C patients to participate, the result was amazing. I mean, we have destroyed hepatitis C. The only barrier now to hepatitis C is detection and diagnosis of it, right? But if we can find these patients, there's hardly a patient you can't cure. And so, I think the goal here is to have a whole slew of liver diseases so that I can retire knowing that, there's no more liver disease to treat. So I think that's really the goal. And, to have to, essentially close down transplant programs because we just don't have people who need liver transplants. Until
Well,
then,
given the,
go ahead.
oh, sorry, given the era that we're in, and you cited hepatitis C as a phenomenal example, what about the COVID vaccines in the clinical trials with that? And you know, that has provided a lot of comfort, although it's been fast-tracked. And can you just talk about like when there's fast-tracked or when there's humanitarian? I think within certain cancers or HIV care, there's no placebo allowed anymore, or sometimes there is. What's that about?
Well, I think it's important to understand that the FDA approaches every disease state in a unique way. You know, for instance, the approval of obeticholic acid for primary biliary cholangitis was really also, in a way, incomplete because the primary outcome there is patients requiring liver transplant. But so few patients with PBC require liver transplant, they elected to use a surrogate marker, which was improvement in alkaline phosphatase or a patient's blood results, right? But the FDA made a deal to continue to monitor patients long-term to see if it did stop the need for a liver transplant. So there's ongoing research going even with that drug. And someday they may say, no, we're not going to use this drug anymore because it doesn't actually stop people from needing liver transplant. And so, you know, the COVID, the way that they approach COVID vaccines was in part because of the need there. But it's still safe. It still involved placebo. It still involved, you know, patients who didn't receive the COVID vaccine, once they deemed it was safe and effective, actually in those clinical trials usually got it first. So there was a process. There just wasn't the same process we do for every disease state. And I think that's one thing that many people might not realize is that there is a kind of algorithm that's a little bit different for every disease state and situation you actually go through. But ultimately, they're looking at safety and efficacy of all these drugs, and they just have different ways of doing it at times.
Excellent. Well, any closing thoughts before I do wrap up?
You know, thank you so much for the opportunity, Scott, to present and, you know, wonderful program you're putting on. Continue the good work.
Excellent, thank you. And I think if you're watching this, you're probably thinking about clinical trials. And like with everything, you might have found information by your doctor, or as Dr. Gutierrez said, you went on the internet. But make sure you have a conversation with your doctor and ask them, is a clinical trial right for me? And learn more about what the options are locally and the pros and cons. And it could be because you can be a hero, or there might be an effective treatment for you. But thank you for joining us tonight for this webinar, our liver Q&A, and for watching the Liver Coalition of San Diego's webinar broadcast. Have a great evening.
Scott.
Good night.